You know, that exact feeling. You wake up, you stretch a bit, you take that very first innocent morning swallow, and suddenly you are wide awake.
Oh, yeah, because it feels like you've just swallowed a handful of crushed glass.
Literally crushed glass and razor blades. It is a highly relatable, universally miserable experience. So, welcome. We are thrilled to have you with us for another deep dive.
And today is a fun one. We are taking your stack of clinical pharmacy guidelines, medical texts, and research papers to decode exactly what is happening in the back of your throat when that morning misery hits.
Right, and our mission here is really twofold. First, we want to separate the common, everyday annoyances from the genuine, medical red flags.
Which is crucial.
Yeah, and second, we want to reveal the surprising evidence-based truth about which over-the-counter remedies actually work and which ones are essentially just, well, expensive, brightly colored candy.
It is a physiological journey that almost every single one of us takes, usually multiple times in our lives. And to really grasp the sheer scale of this issue, consider the numbers from the front lines of healthcare.
The numbers are wild.
They really are. A typical general practitioner in the UK, managing a patient list of around 2,000 people, will see about 120 throat infections a year.
Okay, so that's a decent amount for one doctor.
It is, but that number is just a drop in the ocean. 4 to 6 times that many people simply bypass the doctor altogether.
They just don't even bother making an appointment.
Exactly. They go straight to the local pharmacy to self-treat.
Which is exactly why we are doing this deep dive for you today, because if you are going to be one of those hundreds of people standing in the pharmacy aisle, staring completely overwhelmed at a wall of throat sprays and gargles.
And the dozens of different lozenges.
Right, all of that. You need to be fully informed about what you're actually fighting. So let's start at the very beginning, like the root cause. When we say sore throat, what tissue are we actually talking about?
Well, medically speaking, a sore throat means you are experiencing pain anywhere in the throat mucosa.
Okay, mucosa.
Yeah, that could be your pharynx, which results in a diagnosis of pharyngitis, or it could be localized to your tonsils, which...
Well, it gives you tonsillitis.
Precisely. But the throat mucosa is essentially a continuous lining of connected tissue. So, clinically, the geographic distinction between pharyngitis and tonsillitis is often incredibly blurry.
I mean, it's all right next to each other.
Exactly. The inflammation just kind of bleeds from one area to the next.
So the exact geography doesn't matter as much. What does matter then?
What truly matters is the biological invader causing the problem.
Yeah.
Now, the overwhelming majority of these cases are acute and self-limiting, meaning your body will eventually clear them on its own.
Right. You just have to wait it out.
Yeah. But the vital split you need to understand is this. Between 70 and 90% of all sore throat cases are viral.
Up to 90%. That is a massive majority.
It really is.
Which means the remaining 10 to 30% are bacterial, primarily caused by something your sources identify as group A beta hemolytic streptococcus, right? Or Streptococcus pyogenes.
Yep, commonly known as Strep A.
Right, Strep A. But here is the major issue I see when I look at these clinical guidelines. Trying to guess if a sore throat is viral or bacterial just by looking at it seems, well, basically impossible.
It is notoriously difficult.
Okay, let's unpack this because it feels like trying to guess the exact mechanical failure of a car engine just by staring at the check engine light on the dashboard. It's just a generic warning sign, isn't it?
That is a remarkably accurate way to look at it.
Right.
And the biological reason behind that difficulty is actually fascinating.
Yes, so.
Well, the redness, the sharp pain, the swelling, that mucosal response is your body's generic alarm system. Your immune system doesn't have, like, a different color of inflammation for a virus versus a bacteria.
Oh, right. It just reacts.
Exactly. When it detects an invader, it triggers vasodilation. It simply widens the blood vessels to flood the area with blood, plasma, and immune cells to fight off whatever is there.
So whether it's the common cold virus or a nasty strep bacteria, the throat just gets red, swollen, and angry.
Yep, the visual output is identical. And because up to 90% of these invaders are viral, antibiotics, which only kill bacteria, remember, are completely useless for the vast majority of patients.
Right, because antibiotics don't do anything to a virus.
Nothing at all. And this creates a massive clinical dilemma. Healthcare workers are trying desperately to avoid overprescribing antibiotics to prevent global antimicrobial resistance.
But they're looking down throats that all essentially look the exact same.
Exactly.
Which begs the question, if doctors and pharmacists can't just eyeball a red throat to know if you're in that 10% bacterial minority, how do they actually know? Like, how do they play detective without just guessing?
They rely on rigorously tested algorithms. They're called clinical prediction rules, or CPRs.
Okay.
The National Institute for Health and Care Excellence, or NACE, recommends two major scoring systems to guide this decision-making process.
And those are?
The older classic one is called the Centor Criteria, and there's a newer variation called the FeverPAIN criteria.
FeverPAIN, right.
Yeah, so instead of relying on a visual gut feeling, these are rigid, point-based clinical checklists.
Okay, I want to understand how this scoring works. Let's say I walk into a clinic. What exactly is the doctor looking for to calculate my Centor score?
So with Centor, they're looking for 4 specific things, and each gives you 1 point. First, a fever over 38 degrees Celsius.
Okay, pretty straightforward.
Second, they will feel your neck for tender anterior cervical lymphadenopathy.
Whoa, let's translate that. That's just the swollen, painful glands right under your jawline, right?
Precisely. Your lymph nodes are swelling because they are actively producing immune cells.
Oh,
The third point is for tonsillar exudate.
exudate.
Yeah, exudate, just the medical term for those little white or yellow spots of pus on the tonsils themselves.
Lovely.
I know, right? And the fourth, and perhaps most counterintuitive point, is awarded for the absence of a cough.
Yes. I noticed that in the sources, the absence of a cough actually gets you a point.
It does.
And it's similar in the newer FeverPAIN criteria, right?
It is, yeah. FeverPAIN is an acronym. You get a point for a fever over 38 degrees, a point for purulence, which is that pus or exudate we just mentioned.
Right.
A point if you are attending rapidly, meaning you've come to see the doctor within 3 days of your symptoms starting. A point for severely inflamed tonsils. And finally, a point for no cough or coryza, which means no runny nose or general cold symptoms.
Wait, I need to stop you on that attending rapidly point.
Sure.
If I rush to the doctor within 3 days, I get a point toward a bacterial diagnosis. Does that just mean that being an impatient, highly anxious person who runs to the clinic at the first sign of a scratchy throat actually increases my clinical score for a bacterial infection?
What's fascinating here is that it sounds like it penalizes you for being anxious, but it's actually measuring the velocity of the pathogen.
The velocity, like how fast it hits you.
Exactly. Viral infections usually have a slower, dragging onset. You might feel a bit fatigued on a Monday, get a slight sniffle on Tuesday, and by Thursday, your throat is really starting to burn. It's a
Yeah.
gradual build.
Yeah, that classic incoming cold feeling.
Right. A bacterial infection like Group A strep, however, is a sudden, aggressive strike. You can feel completely fine at breakfast, and by dinner, you are in absolute agony with a spiking fever.
Oh, wow.
It hits you like a freight train. That rapid, severe onset naturally drives a patient to seek medical help immediately.
Oh, I see. It has nothing to do with my personality. It's the fact that the bacteria multiplies so aggressively that I literally couldn't wait a week to see a doctor, even if I wanted to.
Exactly. And that same logic applies to the absence of a cough point you asked about earlier.
Right, because that feels totally backward. You'd naturally assume that more symptoms like coughing and sneezing would equal a worse infection, maybe a bacterial one.
It's a common misconception. But viruses, like the rhinovirus or adenovirus, are inhaled and tend to irritate the entire upper respiratory tract.
So they get everywhere.
Yeah, they infect the nasal passages, the throat, the vocal cords, and the upper airways. That widespread irritation is what causes the runny nose and the coughing.
So a virus is like a chaotic invader that just sets fire to the whole neighborhood.
That's a great way to picture it. Bacteria, like strep, on the other hand, are highly specialized. They tend to find one specific location, in this case, the crypts of your tonsils, set up camp, and multiply rapidly right there in that one spot.
Yeah.
So a terribly sore throat with pus, a high fever, but absolutely no widespread respiratory symptoms like a cough or a runny nose, strongly points to a localized bacterial strike.
That makes total sense when you look at the mechanics of it. So we have our scoring tools Centor and FeverPAIN to handle this standard viral versus bacterial split.
Yep.
But what happens when the clinical math just doesn't add up, like when we are dealing with the outliers? Because the guidelines spend a lot of time warning about unlikely pauses and red flags.
And those red flags are critical because a sore throat isn't always just a simple throat infection. Sometimes the throat is just the canary in the coal mine for a much larger systemic issue.
Okay, like what?
A perfect example of this is glandular fever, medically known as infectious mononucleosis.
Right, the classic kissing disease, caused by the Epstein-Barr virus.
That's the one.
The clinical texts note that this peaks heavily in teenagers, specifically 15 to 19-year-olds. It brings severe fatigue and malaise that feels totally disproportionate to the throat pain.
Which is a key indicator.
But there's a detail here that completely threw me. Hold on, how does the plumbing connect here? Because the guidelines state that in approximately 50% of patients with glandular fever, they develop an enlarged spleen.
Yes, cleinomegaly.
Why on earth does a throat infection like glandular fever end up physically swelling an organ in your abdomen?
If we connect this to the bigger picture, it highlights just how interconnected our lymphatic and immune systems are. You see, glandular fever isn't just a localized throat infection.
Okay.
The Epstein-Barr virus specifically targets a type of white blood cell called a B lymphocyte. The sore throat you feel is just the entry point. The virus first encounters your immune tissue at the tonsils.
So it's just passing through,
Yeah.
basically.
Right, but once it infects those B cells, it hitches a ride and spreads throughout your entire lymphatic system.
And the spleen is part of that system.
The spleen is essentially the largest lymph node in your body. It acts as a massive blood filter. So as your immune system detects this systemic viral invasion, it goes into overdrive, producing millions of specialized immune cells to hunt down the virus.
Oh, I think I see where this is going.
All those cells pack into the spleen to do their work. The spleen physically swells up, sometimes dangerously, so simply to handle the massive biological workload of this immune war.
That is wild. The throat is literally just the beachhead where the invasion lands, but the actual war is raging down in the spleen.
Exactly.
Let's pivot to another red flag, one that really surprised me. Medication-induced sore throats.
This is a rare one, but it is an absolute medical emergency. Certain prescription drugs such as captopril, which is used for blood pressure, or clozapine for schizophrenia, or sulfasalazine carry a rare side effect.
What do they do?
They can cause neutropenia or, in severe cases, agranulocytosis.
Which means the medication accidentally wipes out your body's white blood cells.
Yes.
But wait, if a blood pressure pill crashes your immune system and destroys your white blood cells, why is a sore throat or mouth ulcers the very first symptom you experience? Like, why wouldn't your skin hurt or your lungs?
Because of the oral microbiome. Your mouth and throat are naturally teeming with billions of bacteria at all times.
Right, gross, but true.
Normally, your white blood cells are constantly patrolling that mucosal border,
Hmm.
keeping those opportunistic bacteria completely in check without you ever knowing it.
Ah, so the moment the white blood cells disappear, the bacteria that are already living in my mouth just cross the border and start attacking the tissue.
Precisely. The shields go down, and the resident bacteria immediately overrun the mucosa. So a sudden, severe sore throat in someone taking these specific medications is a massive red flag that their bone marrow has stopped producing immune cells.
Okay, noting that one down. That is terrifying. The guidelines also distinguish heavily between throat pain and mechanical dysphagia.
Yes, that's another massive red flag. Dysphagia means difficulty swallowing. Now, a normal sore throat hurts when you swallow, so you might avoid eating. That is pain.
Right, it just stings.
But true mechanical dysphagia means there's an actual physical blockage. The patient physically cannot get food or liquid down the esophagus.
Wow, okay.
If it feels like something is in the way, that requires urgent investigation to rule out serious structural issues, like a peritonsillar abscess, which is a severe collection of pus blocking the airway, or even a carcinoma, a cancer.
That is definitely a doctor visit.
Absolutely. The same urgency applies to any throat symptom, pain or otherwise, that lingers for more than 14 days without improving.
And before we leave the red flags, we have to talk about scarlet fever.
Yes.
It sounds like a disease from an 1800s Victorian novel, but it's still very real.
Very much so.
It's caused by the same Strep pyogenes bacteria we discussed earlier. The sources say it starts with a sore throat and a fever, but then the patient develops a rough, sandpaper-like blanching rash that spreads from the abdomen.
And don't forget the tongue.
Right, accompanied by a strawberry tongue. What is a bacteria actually doing to cause a strawberry tongue?
It all comes down to toxins. Some strains of the strep bacteria produce what are called erythrogenic toxins. Erythro meaning red.
Oh, right.
These toxins are secreted by the bacteria in the throat, but they enter the bloodstream and circulate through the body. They specifically damage the tiny capillary blood vessels in the skin and the mucous membranes.
So they're attacking the blood vessels directly.
Yeah, this toxic damage causes the capillaries to dilate and leak slightly, which creates that red, raised, sandpaper-like rash on the skin. And it causes the taste buds on the tongue to become incredibly inflamed and swollen, giving it that pitted red strawberry appearance.
That is endlessly fascinating. The bacteria is basically poisoning the blood vessels from its home base in the tonsils.
That's a good way to put it.
Okay, so armed with all this diagnostic knowledge, avoiding the red flags, you finally walk into your local pharmacy with your standard, painful, run-of-the-mill sore throat.
The dreaded pharmacy aisle.
Exactly. You are looking at that massive wall of products. What does the clinical evidence actually say about all those brightly colored boxes?
The evidence base is incredibly eye-opening, and honestly, if you believe the marketing on the boxes, it's frankly a bit disappointing.
Oh boy.
Let's start with the most popular ones. Local anesthetics, things containing lidocaine or benzocaine.
The numbing ones.
Right. They do work to numb the tissue, but they have a very short duration of action, meaning you have to keep taking them constantly.
Yeah.
And there was a clinical trial specifically looking at lidocaine lozenges that showed absolutely no difference in pain relief between a 1 milligram dose and an 8 milligram dose over a 2 to 4 hour period.
Wait, really? So when I pay extra for the box that screams maximum strength 8 milligrams in huge letters, I'm not actually getting more prolonged relief than the standard dose?
According to that trial data, no. The extra medication didn't translate to significantly better clinical pain relief over that time period. You are essentially maxing out the local nerve receptors very quickly.
Wow, marketing at its finest.
Yeah, but a much bigger issue in the pharmacy aisle involves antibacterial and antifungal lozenges. In a lab, in a petri dish, yes, they show antibacterial properties. But the clinical guidelines are absolute on this. They should not be routinely recommended to patients.
Which makes perfect sense based on what we established earlier. Up to 90% of these sore throats are viral.
Exactly.
Using an antibacterial lozenge on a viral sore throat is like putting out rat traps when your house is infested with termites. You're targeting the entirely wrong biological kingdom. It's not going to do anything to the root cause.
That is a perfect analogy. You are attacking an enemy that isn't there. And furthermore, there are serious global health concerns that constantly exposing our oral microbiomes to low-dose antibacterials in these over-the-counter sweets is contributing to antimicrobial resistance.
Oh, because the surviving bacteria mutate and get stronger.
Right. This concern was taken so seriously that throat products containing the antibacterial agent tyrothricin were actually forcibly withdrawn from the market in 2020.
Wow. Okay, so antibacterials are mostly out. What about anti-inflammatories? There is a major bombshell in our sources regarding flurbiprofen lozenges.
Ah, yes.
Yeah,
Flurbiprofen. Flurbiprofen is an NSAID, right? A non-steroidal anti-inflammatory drug, similar to ibuprofen. Now, the data does show they are more effective than a sugar pill placebo at reducing pain.
They do, yes.
However, a major review in Prescriber International concluded that flurbiprofen lozenges actually have a negative risk-benefit balance.
Yes, and the pharmacological reason for that negative balance is important. When you deliver an NSAID locally via a lozenge, you are exposing the local throat tissue to the drug, but as you swallow your saliva, you are still absorbing that drug systemically into your bloodstream.
So it's still getting everywhere anyway.
Exactly. So you're carrying all the usual systemic NSAID risks like stomach irritation, gastrointestinal bleeding, or kidney strain without necessarily gaining a massive localized pain relief advantage over just swallowing a standard ibuprofen tablet. Here's where it gets really interesting. The review's conclusion was brutal. I am quoting this directly. It is better to suck real sweets, and if necessary, take paracetamol.
Yep.
So buying expensive medicated flurbiprofen lozenges is basically buying slightly risky hard candy when a cheap, generic paracetamol pill does the actual heavy lifting.
It is a very blunt assessment, but medically it holds up perfectly. The physical, mechanical action of sucking on any hard sweet stimulates your salivary glands.
And saliva is good, obviously.
Right, that extra saliva physically lubricates and soothes the dry, inflamed mucosa of your throat. That simple mechanical action is providing a huge portion of the relief that people mistakenly credit to the expensive medication inside the lozenge.
Huh. That brings up the old school home remedies. Gargling with salt water or gargling with soluble aspirin. My grandmother swore by hot salt water. Why aren't those on the recommended list?
They are very common lay remedies, deeply ingrained in our culture. But the clinical reality, literally zero formal clinical trials appear to have been conducted to prove their effectiveness. None. And because modern pharmacy operates on evidence-based medicine, until that trial evidence becomes available, the guidelines state they shouldn't be formally recommended by pharmacists.
But let me push back on that for a second. Is there zero evidence because salt water genuinely doesn't work? Or is there zero evidence simply because no pharmaceutical company is ever going to fund a multi-million-dollar double-blind clinical trial to prove the efficacy of warm tap water and table salt? There's no patent there. There's no profit.
You've hit the nail on the head regarding the limitations of evidence-based medicine. Funding drives research. Biologically, salt water can help draw out fluid from swollen tissues via osmosis, which makes logical sense.
So it probably does work on some level.
Likely, yes. But without the rigorous trial data, a clinical body like NICE cannot officially put it in a medical guideline. They can only recommend what has been proven in controlled settings.
Okay, so cutting through all the marketing, what actually does have proven gold standard evidence?
Simple systemic analgesics. Good old paracetamol and ibuprofen. Studies consistently show they are highly effective at reducing the pain and the fever associated with the sore throat when taken regularly at the correct doses.
Just the basics then.
Yep. And if a patient absolutely wants a localized treatment, benzidamine, which comes as a medicinal rinse or a spray, actually does show significant proven relief of pain compared with a placebo in proper clinical trials.
Okay, so benzidamine is a real option, but this raises an important question. If the vast majority of pharmacy products are essentially just glorified saliva stimulators, and 90% of cases are viral anyway, how does the medical system handle the 10% of patients who genuinely do need antibiotics but decide to bypass a doctor and go straight to the pharmacy?
Do they just fall through the cracks?
Yeah, do they just go home with useless lozenges?
They used to, but this is where the landscape of healthcare is shifting beautifully.
Yeah.
We now have pharmacy-first schemes.
Okay, what does that mean?
Highly trained pharmacists are no longer just pointing people to the lozenge aisle. They are using patient group directions, or PGDs, to legally supply prescription antibiotics, like penicillin or macrolides, directly to patients over the age of 5.
Wait, pharmacists can prescribe them now?
Yes, but, and this is the crucial part, they do not do it based on a visual inspection or a gut feeling.
Oh, they use the CPRs. They pull out the Centor and FeverPAIN criteria.
Exactly. For a pharmacist to legally authorize and hand over those antibiotics, the patient's fever pain score must be a severe 4 or 5.
They have to hit almost every symptom on the list.
Right. They rigorously check the fever, the pus, the velocity of the illness, and the absence of a cough. It shows how strict, mathematical, evidence-based scoring is completely replacing the old throw everything at the wall and see what sticks approach.
Which is amazing.
It ensures the patient gets the right care, and it rigorously protects our global antibiotic supply from overprescription.
So, to summarize this incredibly enlightening journey through the back of your throat, we have learned that up to 90% of the time you wake up swallowing those razor blades, your immune system is simply dilating blood vessels to fight an invisible viral war.
Spot on.
We've learned that the absence of a cough is actually a critical, counterintuitive clue that you might be dealing with the 10% bacterial minority because bacteria localize while viruses spread.
Yeah.
We've mapped out the terrifying red flags from the spleen-swelling systemic warfare of glandular fever to the medication-induced crashing of your white blood cells.
Also very true.
And perhaps most practically for you listening right now, we've learned that you are probably much better off just sucking on a regular boiled sweet to generate soothing saliva and taking a standard paracetamol rather than spending a fortune on fancy, brightly colored throat sprays and mildly risky medicated lozenges.
It really completely reframes how you look at the medicine cabinet and the pharmacy aisle, doesn't it?
It totally does.
And as we wrap up today, I want to leave you with a thought to mull over, building entirely on the logic of the FeverPAIN criteria and where medical technology is heading.
Oh, I like where this is going.
We just talked about how strict criteria-based scoring like FeverPAIN is now used by pharmacists to dispense antibiotics. Since diagnosing a bacterial sore throat is essentially now just a rigid algorithm, a symptom checklist and a temperature check,
Yeah.
how long will it be until an AI health app on your phone uses your high-resolution camera to look at your tonsils, cross-references a digital symptom survey to calculate your Centor score, and automatically authorizes an antibiotic drone delivery right to your front door?
Oh.
Right. Are we looking at a rapidly approaching future that bypasses human doctors and pharmacists entirely for these acute, localized infections?
That is a wild, wild thought. Going from waking up with razor blades in your throat to having a drone drop off precisely targeted penicillin before you've even finished breakfast.
It's probably closer than we think.
I bet it is. Thank you so much for joining us on this deep dive. We hope you feel incredibly well-equipped, informed, and maybe just a little less anxious for the next time those winter bugs come around. Keep questioning the labels, keep seeking the evidence, and stay curious. See you next time.